into the UK's National Health Service.
Right.
Specifically, something called Clinical Documentation Integrity, or CDI. And our mission today is, well, it's to show you how a doctor's handwriting or typing can be the single biggest risk to a hospital trust's finances.
It sounds dramatic, but it's true. We're tracing the money. How a simple clinical note determines millions in income for the NHS.
It all starts with this idea of a dual mandate for the documentation, right?
Exactly. On one hand, you've got clinical governance. So is the care safe? Is it person-centered? Is it meeting CQC standards? All of that.
The stuff patients care about.
Yes.
Okay.
But on the other hand, it's a financial and informational asset. And if that clinical narrative is weak, the trust, well, it just loses funding. It also opens itself up to a massive audit risk.
And this is all under the payment by results system, the PBR. So you need good records. There's a standard for this, isn't there? Carrot.
That's it. Complete, accurate, relevant, accessible, and timely. If the notes fail that carrot test, you get a downstream problem.
A problem with the codes used for billing.
Precisely. The statistical codes for diagnoses, that's ICD-10, and for procedures, which is OPCS 4, they get compromised.
So to really get this, you have to understand the data architecture. You said it has 3 layers.
It does. Layer 1 is right at the point of care. It's what the clinician uses. It's a system called SNOMED-CT.
Systematized nomenclature of medicine clinical terms.
You got it. It's incredibly detailed, very precise clinical language. It goes straight into the electronic patient record.
Okay, hang on. If SNOMED is so detailed and accurate for the patient, why can't we just use that for the billing and the stats? Why bother with another layer?
It's a great question, and the answer is it's too granular. It's clinical language, not accounting language. You can't manage a national health service with that level of detail.
I see, so you need to aggregate it.
You do, and that's layer 2. That's where ICD-10 and OPCS 4 come in. They create the financial currency, which is called a healthcare resource group, or HRG.
The HRG is the payment tariff.
It's the payment for that whole bundle of care. So the bridge between layer 1 and layer 2, that's the critical moment.
That's where it all flows perfectly.
Or it crashes spectacularly. And it crashes if that initial SNM documentation is vague. If a doctor just writes, say, history of breast cancer, the system can only map that to a really non-specific code.
And that non-specificity is where the money is lost. Instantly.
You lose the claim for the complexity of care, which is why you have the human element, the accredited clinical coder, the ACC.
So we're relying on a person to interpret what might be ambiguous notes. That doesn't sound like simple transcription. That sounds like incredibly risky.
It's highly skilled interpretation, and when the notes are insufficient, maybe they're missing the laterality, left or right, or the status of an old disease, the coder has to step in.
What do?
They initiate a clinical query. This is where it gets serious. The query has to be, and this is crucial, non-leading.
For audit protection.
Oh.
You can't put words in the doctor's mouth.
Absolutely not. You can't ask, was the cancer active? You have to ask, please specify the current status of the historical malignancy. See the difference. Neutral.
And that process, that back and forth, that is CDI in action.
That's it. Fixing that tiny bit of specificity ensures the right ICD-10 code is assigned, which gets you the right HRG and the correct justified reimbursement.
And looking forward, this is only getting more important. The NHS is moving to ICD-11 soon.
Which demands even more granularity. You'll have to specify laterality, episode of care, all sorts of things. The CDI work today is basically practice for what's mandatory tomorrow.
So if you don't fix this data quality problem now,
the switch to ICD-11 could trigger a systemic collapse in data quality.
So let's bring this all home for you. The takeaway is that documentation integrity isn't just some back-office admin task. It might be the single most significant point of failure in the entire NHS data lifecycle.
It directly hits the money and future compliance.
Which brings us to a final provocative thought. Automation. Everyone wants automated clinical coding for efficiency.
Of course. But the real goal here isn't just speed. It can't be.
The number one priority has to be auditability. The question you really need to be asking about any new AI system is this. Can it provide an explainable, rule-based reason for every single code it assigns?
Because if it can't, it won't stand up in an audit, and that could be a catastrophic regulatory risk.